start with our usual introductory slides. So today is the third instalment of the Compassionate Clinical Care, a three-part series on neglect. This is part 3, exploring the current evidence for best practice recognition and response to neglect in diverse populations. My name is Carla Wilkie and I'm the facilitator for today. I'm the Elder Abuse Prevention and Response Liaison Officer in Melbourne's Western region. And I, along with my colleagues, work on the Integrated Model of Care for Elder Abuse project, which is a Department of Health project that was rolled out in 5 regions across Victoria. So that's West, North, Peninsula, Monash and Latrobe. This project chiefly aims to enhance workforce capability to recognise and respond to in a person-centred and family-inclusive manner to elder abuse. The 4th arm of the Integrated Model of Care project is the Elder Abuse Prevention Network. And that is what this forum was derived from. So we asked people during this, I guess, more challenging 18 months, what was it that they wanted to hear more about in terms of their professional development, and neglect consistently flowed through, and that's where these were born from. My co-pilot today is Grace Webster from Merri Health, who is the project officer for the prevention arm of the Integrated Model of Care project. Grace will be supporting us with the tech, and we'll both be monitoring the chat and Q&A for your comments and questions. Grace, do you have anything to add?
Yeah, I was just going to speak maybe briefly just about the North and West Metro Elder Abuse Prevention Networks and what our role is. So the EAPN network is a network of service providers that meet bi-monthly to promote and plan for elder abuse primary prevention and awareness activities and events, as well as share resources and discuss experiences of working with older adults. Together, the EAPN network held a World Elder Abuse Awareness Day activity, which consisted of an art exhibition to promote positive ageing messaging. A link to the video will be shared in the chat if anyone wants to have a look at it, and it shares what local residents believe ageing to mean to them. The future direction of the Elder Abuse Prevention Networks is to focus on diverse communities, which is particularly important in the Western region of Metro Melbourne. So this webinar focusing on diversity and neglect is the first step of many towards our work in this space. So we ask if you are facilitating any projects in the elder abuse awareness domain and would like any support from the networks, please get in contact with either Carla or myself. I'll put both of our email addresses in the chat. Also, if you're interested in joining the network, please get in contact. We'd love to have as many representatives from organisations as possible. Thanks, Carla.
Thank you, Grace. We've got a little bit more housekeeping additional information to share with you. So we would like to begin by acknowledging the traditional custodians of the lands from which our hospitals, services and homes meet today, and pay our respects to their elders past, present and emerging. For myself and Western Health, we are on the land of the Wurundjeri, Bunurong and Boonwurrung peoples of the Greater Kulin Nation. And we also respectfully acknowledge any First Nations people joining us today. And we'd like to further note that we come to you from stolen land, which was never ceded, and to acknowledge the tremendous impact that colonisation has had on Aboriginal people in the past and present. If you wish, please do acknowledge in the chat the traditional owners of the lands on which you are joining us from today. And you might also like to share your name and your which service you come to us from, as we haven't had a lot of professional networking opportunities over the last 18 months. So we found these webinars to be a great source of connection. We'd also like to acknowledge the particular resilience of older people who have survived elder abuse or are living with elder abuse at this time. And additionally, if during this session you find that the content makes you feel uncomfortable or distressed, please feel free to disengage or participate in a way that supports your needs. So for publicly employed clinicians, there's Karanish at Work, and then the 3 national helplines of Lifeline, Beyond Blue and Respect Victoria. And just to highlight the main players in the family violence services in the West, the top box there is provided to us by the Strengthening Hospitals Response to Family Violence group. And it's not an exhaustive list, but it's certainly a list of some important services that are available in the West. The bottom box, the top two numbers are elder abuse hotlines. So there's Seniors Rights Victoria and 1-800 Elder Help. And you can also do secondary consults through Better Place Australia. And within the Western region, as part of this project, I also undertake secondary consults to support clinicians working anywhere in the Western region, both inside Western Health and outside Western Health. And that's my mobile number there, 0423 842 103, and that's during business hours, Monday to Friday. So in terms of our content for today, we're going to be covering the evidence for neglect. So looking at the neglect fundamentals, but also a deeper dive into what evidence there is related to diversity or intersectional factors related to neglect. So inclusive of dementia, culturally and linguistically diverse communities, potentially mental health, and lesbian, gay, bisexual, transgender, queer, intersex, and whatever else our experts are able to present to us. We'll also be speaking to some aspects of prevention of neglect, including a focus on advanced care planning. So today we are most pleased to have our experts along. We've got two experts on our panel today. The first being Professor Bianca Brijnath, who is the Divisional Director of Social Gerontology at the National Ageing Research Institute, known to us all as NARI. And we also have a bit later on, Claire Thurstans, who's a lawyer and project lead with the Health Justice Partnership with CoHealth, and is working on a project safeguarding now preventing future abuse. So I'll just introduce Bianca, and then we can go forward from there. So Bianca Brijnath is back after overwhelming positive feedback that we had from her contributions to our webinar this year for World Elder Abuse Awareness Day in June. Most attendees will be familiar with Professor Bianca Brijnath's wide body of work in the elder abuse space. And also she's been super busy, not only with us this year, but also presenting at a number of other forums and undertaking timely research in the context of COVID and elder abuse. Bianca's research expertise is in cultural diversity, dementia and mental health. And within these contextual boundaries, she has produced a wide body of literature exploring mental health and culture, mental health and life course, dementia and cultural diversity. Professor Bianca Brijnath has authored over 100 publications, including a sole-authored book, Unforgotten Love and the Culture of Dementia Care in India. Today, we'd also like to extend our congratulations to Professor Brijnath for her recent progress to the title of Professor, which is most well deserved. And I'd like to welcome Bianca. I'm just going to unshare my screen.
Wonderful. Thank you so much, Carla, for that very generous introduction and for inviting me back to present again. It's a real treat to be here. I always find invitations from Carla and from Western Health push and challenge me in different ways and to think about complex issues in different ways. So inevitably, I come to these lectures with fresh ideas and different perspectives. So I can't promise I'll get it right all the time, but certainly I hope I give you food for thought. So I'm going to start by sharing my screen, and I hope it will come up soon. So you should be seeing the kind of edit version. Now I'm going to just hit that. Now, are you seeing the notes page or the full screen?
We've got the full screen. That looks good.
Beautiful. All right. Well, like I said, thank you today for inviting me to talk about neglect and diversity. It's a complex issue, in part because there's very limited evidence in this space. But I'll do my best. What I'm going to do in my talk today is three parts. The first one is I'll give a really quick review of the evidence base for neglect. I know this is the third part in a series, so you're probably well versed on the kind of basics, but we'll just do a quick recap. Then I'll explore some of the intersectional factors that impact risk of neglect and sort of the current presentations of neglect that you might see. And then I'll talk a little bit about some alternative models and approaches that we might take both to the response and prevention of neglect. So, and I'll end a little bit, I'll forecast this in advance, I'll end a little bit on a theoretical note and try and drawing on very much my kind of anthropology roots, but hopefully it won't be too esoteric. All right, so just a super quick review of the basics of neglect. So the definition of neglect as per Compass, which is a wonderful website. If you have not been yet, please do go consider going there. It's a fantastic clearinghouse for Australian work on elder abuse. As per their definition, neglect is a failure of a carer to provide basic necessities such as food, shelter, or medical care, or preventing someone else from providing them. Neglect has several components to it. One is it's intended, so the perpetrator is deliberately withholding care and those sort of basic amenities that we talked about. It could be unintended insofar as the carer themselves or the perpetrator themselves has issues that inhibit them providing effective care to an older person, whether that is because of poverty or carer burnout or distance or a whole suite of issues. There's also self-neglect, which is a bit of a controversial issue because is that really a form of elder abuse, or is that a form of, people, I guess, intrinsic frailty or ongoing mental health issues that might be inhibiting that. And then there's also neglect that's perpetrated by others. So not just by the self, but by other people as well. So various overlapping areas in those various circles. There are different signs of neglect that it's important to pay attention to from the victim side. Again, this is from the Compass website, but from the victim side, it's very much around, requesting, begging, scavenging, or stealing food, constant fatigue, listlessness or falling asleep, direct or indirect disclosure of neglect, extreme longing for company. Social isolation is very common for people who are neglected, anxiety about being alone or abandoned, and displaying inappropriate or excessive self-comforting behaviors. The physical signs of neglect often, the older person's often inadequately clothed. They often complain about either being too cold or too hot. They've got poor personal hygiene or an unkempt appearance. I know many ACAS workers, for example, will tell us when they walk into a property in the days before when you could actually visit people, you'd walk in and you get a smell and you immediately something wasn't quite right. You could smell something was not right. So definitely that's a great indicator. Lack of medical or dental care, injuries that have not been properly cared for, absence of required aids, exposure to unsafe, unhealthy, or unsanitary conditions, unexplained weight loss, dehydration, poor skin integrity, malnutrition. And then from the perpetrator side is, again, that failure to provide those basic needs, but also under and over medication. That's a critical issue. Exposure to danger or lack of supervision. So you often leave a vulnerable person in an unsafe place, or they're isolated for prolonged periods. Or you're very overly attentive in the company of others and also refusing to permit others to provide appropriate care. So it's quite full on actually, these indicators. So, I won't go into more depth around what you might actually see in practice. I'm pretty sure you've all seen some fairly hairy and horrific things. Neglect is, in terms of the broader umbrella of elder abuse, very underreported. And therefore, its prevalence, both globally and locally, tend to be quite low. So globally, the neglect is sort of estimated around 4.2% of all kinds of elder abuse. So if you think about it in the context of financial abuse or psychological abuse, where you have much higher rates of 12 and 15%, this is relatively low. Likewise, of our analysis of seniors' rights data for 7 years in Victoria, we found the prevalence of neglect in that work to be about 1.22% based on about 3,000 phone calls over 7 years. So again, very low. But like I said, it's a very difficult concept to measure. By virtue of a person being neglected, they are unlikely themselves to have the capacity in many instances to seek help and to ring a helpline or to answer a phone call on a prevalence study from some random survey on that's coming out of the blue. So that in part makes it really very challenging. And we've certainly got studies from Australia themselves that suggest that the incidence of neglect is much higher. For example, the Australian longitudinal study on women's health suggests that neglect could be as high as 20% amongst older women. And likewise, the New South Wales Elder Abuse Hotline suggested that 25% of calls were related to neglect. And often these calls are coming in from neighbors or extended family or people around the older person themselves. So it's not a straightforward concept. Now, we often tend to talk about neglect in the context of family and community. But in fact, the Royal Commission titled its interim report Neglect. And when they looked at what they considered neglect in residential aged care, they estimated it as high as 30%. That's really high. And there were legitimate and grave concerns about how older people were assisted to undertake activities of daily life, such as showering or toileting or eating, about how medication was managed, whether people were over-medicated or under-medicated, how wounds were managed. I mean, we've certainly seen a lot of horror stories in the paper about things like that, about facilitating timely access to general practice, to dentistry, to mental health services and other allied health, and even care staff having inadequate time to actually spend with residents to attend to their individual needs. And I know we've all seen those four corner stories and looked at what's come out of the Royal Commission. So it's a really timely reminder in some ways when we think about neglect to take a broad view of it, because when we talk about neglect in residential aged care, we tend to kind of disguise it under the rubric of, it's a serious incident response. No, it's abuse. That's how we have to think about it. It's not a serious incident response. We must not obfuscate it by language. We need to tackle the issue head on to deal with it properly. So I think that's an important point just to note. Now, when we talk about neglect and intersectionality, there are a number of issues that do need to be thought about. But it's again, an interesting area to explore because there's not too much literature around. But I want to start by just reflecting a little bit on a phone call I received last year from a journalist at SBS who asked me to comment on this particular story that got written up. And the first question the journalist asked me was, what advice would you give to a called family that wanted to withdraw their loved one from residential aged care to protect them from COVID-19? And I was astounded by this question because to my mind, I thought, well, actually, I wouldn't recommend withdrawing them necessarily. I think that's a terrible idea because the very high care needs that required their admission into residential aged care those haven't necessarily disappeared. Then I thought about it some more and I thought, well, but this is really tricky because if COVID is rampaging through residential aged care as it was last year in Melbourne, then, people have a right to be legitimately concerned. They might think, well, actually, maybe my loved one, my mother, my father is safer at home with me and I can kind of, look after them until things settle down again. So it became a really tricky issue to kind of navigate both ethically and in terms of providing advice. So I don't know whether I adequately provided a response. I did say, look, you need to think about it really carefully because if you're doing this sort of work and you're withdrawing a loved one from resi care to look after them at home, and there's a concurrent withdrawal of home care services, then you're really on your own. And that's a dangerous place to be, I think, in some respects. And certainly, we saw things in the media that concorded with this. For example, we know that, St. Basil's was in fact, many ways the epicenter of last year's deadly outbreak. And that was a Greek ethno-specific aged care facility. And there was a real worry there that as COVID went through it, actually the neglect of all the residents was enhanced because they were so busy dealing with older people who were grappling with COVID, but there was a concern that others were not receiving enough care. And in fact, that people were going to starve because there's not enough people there to feed them. Likewise, in Epping Gardens in the northwest of Melbourne, 6 staff showed up for work when COVID took hold. So they had to, redeploy staff from St. Basil's again to go up there and look after the residents there as well. So, resources really being stretched to the max and people struggling quite a bit. We did some work recently looking at how services, frontline services, including hospitals, aged care, police, ambulance, etc., responded to elder abuse in the context of COVID-19 and what you have all been dealing with. So here's a quote from some of that study, and across the board, didn't matter where in Melbourne it happened, and it didn't matter which service we were necessarily talking to. There was routine reports that neglect was, the prevalence of neglect was increased, and people were seeing much more neglect as a consequence of the pandemic. So this particular staff member from St. Vincent said, we see it in terms of neglect, intentional neglect, unintentional neglect. We see it in terms of blocking access to services. In terms of adult children moving back into the property with the elderly parents, we see it in terms of misinterpretation when a patient is speaking a language other than English. So the perpetrator is controlling that flow of information by insisting on being the interpreter and then misinterpreting what's said. So lots of different dynamics coming together there in the context of neglect and diversity, including people insisting on being interpreters, sequestering the older person, moving back into their property, then neglect being both intentional, unintentional, etc. I wanted to just bring to your attention this model. Look, it's a complex one, but I thought it was a really interesting one about how we might think about neglect and diversity. And really to first acknowledge that this model is the work of the authors that I've listed there in the reference. And what I did with this model when I looked at it was I adapted the language, and that's the bits in green. I just kind of made it a bit more age-friendly. And I also popped in a few of my own additions because I thought, yep, there are a few more things here that we could add to the mix in the Australian context, at least, to help us think through neglect and diversity. So I guess, look, I'll start from the beginning. Don't worry if you don't get it all. It's fine, I'll come back to it. But if we look at the microsystem, which is really the interaction between the perpetrator, the older person, and the extended family, what we often see in the context of neglect is obviously increased dependency. We see increased social isolation. There is an intergenerational component quite often, where most of the time perpetrators tend to be adult children. And quite often there's also a denial or minimization of the abuse because it's not necessarily explicit all the time, right? So it's not that, even if it's especially if it's unintentional, the person's not, actively setting out to hurt the older person, but by their actions or inactions are actually doing so. Obviously, neglect occurs in a context where there may be a stressed family network. Certainly, we've seen that in light of COVID, and where carers themselves might have limited access to culturally relevant services. In terms of the macro system, and with regards to the risk factors, we know internalized racism, institutionalized racism, and structural segregation. So, limited English proficiency in Australia's English-speaking health systems and aged care systems. So limited English proficiency, limited access to interpreters, inadequate use of interpreters, insisting on family members being interpreters. All of those sorts of barriers will actually compound abuse, particularly neglect. We also know that there's a historical legacy of colonization and the impacts of the stolen generation that will influence particularly Aboriginal and Torres Strait Islander communities and their access to health and aged care services, and how abuse is kind of mediated through those particular prisms, and the perceived cultural safety and approachability of existing services. Likewise, health vulnerabilities are often compounded within these environments, and we have homophobia and discrimination that also creep in. So these are some of the big picture, risk factors that will shape neglect. And of course, last but certainly not least is poverty. Now, I'm not going to talk about the protective factors just yet. Don't worry, I promise I'll come back to them. But more here, I guess, to talk about neglect in culturally diverse families. Here's a quote from someone who actually works at Western Health and what they told us in the study last year. So they said, look, Particularly with Vietnamese cultural groups, elders, the children, and generations living together in one household, providing care and respect for their elder, it's a breeding ground for carer stress. So if we think back on that model I talked about earlier, you've got the dependencies coming in, right? And these elders have grown up in a time when receiving care from their children is expected. So some of that cultural expectation, those sort of meso-level factors. So the thought of aged care or accepting more services into a home, it's kind of seen as this big, oh no, we'd be complete failures if we had to even think of aged care or services. So also a lack of culturally safe services is kind of perception that people are abrogating their familial responsibilities. And so a lot has fallen onto families, especially if they're working from home and needing to juggle caregiving of children and other dependents as well. And that will amplify stress. I mean, all of us at the moment are juggling many competing responsibilities. So we all know that there is an increased level of stress that we are having to deal with. And it's been compounded by all of that external stresses from finances, jobs, caring from home, services cancelling, and deteriorating health. And so definitely poverty being one of the defining features of this last almost 18 months of life, where yes, some people have done relatively okay, but a lot of people have really suffered quite a bit. And poverty is as a way of really enhancing neglect in many families. Likewise, neglect is also pervasive in some LGBTQI older communities. This is work that was done overseas. So I'm going to kind of just reproduce the model that they themselves described. But one of the things that enhances the risk of abuse and reduces access to services for LGBT communities is obviously ostracism from the biological family because of their status as a lesbian, gay, or bisexual or trans person, which ultimately can also in later life means that they might have reduced access to caregivers and to housing options. If there's been a prior history of violence or abuse, then likely that might continue into later life. If there's been an increased prevalence of HIV, then again in later life that will compound the risk of abuse because there's increased vulnerability to physical and cognitive impairment. We know, for example, HIV-related dementia can occur in later life. There's income discrimination and lack of spousal benefits. So you have reduced access to housing and caregiving resources due to lower income. And also poor interactions with law enforcement and medical providers, creating increased mistrust and reduced likelihood of reporting to these services and seeking help from them. And also, I guess, heteronormative experiences with many services and that kind of, especially in aged care, that kind of heteronormative construction of how services are delivered and who we imagine older people to be means that many older gay and lesbian and trans people may be less likely to engage with these traditional support services and will definitely avoid long-term care for some of those barriers. Neglect and dementia also, of course, is extremely common, driven by many factors, including family stress and carer stress. This is a quote from a staff member at Melbourne Health who said, look, there's a lot of carer stress, carer burnout issues. So I'm hearing a lot more about older people coming into hospital with significant neglect or care issues. So these would be older people with often quite advanced dementia. Oops, sorry, 1 second. That's my dog making a racket. I'm just going to chuck her out of the room. Please bear with me. Yes, as you can see, the perils of working from home. And going back to talking about neglect and dementia. And so the very real sense is that family members have struggled through COVID, either because the service providers have done that, they've reduced the services, or more commonly, as I've said, it's because families have not had services coming in. So there's been that kind of dual tension where both services have been withdrawn and families themselves have said, no, we don't want, the risk of people coming into the house who might be infected with COVID or carrying COVID into the property. So they're not using residential respite, and they're also not considering permanent care. Really going back to the very question I brought up at the beginning that the journalist asked me, which is, what advice would you give? And it's a really tricky one because there really is no good advice to give in some respects. But one of the things we also tried to do, and this is this film I'm going to show you now is a couple of years old, but I think it does unravel some of those tensions around neglect and what you might see in a community-based setting at least, and what you might think about doing when you come across these instances of it. So I'm going to play this film for you, and I hope you can, the sound comes across well and it's all good. But feel free to, Carla or Grace, feel free to jump in and tell me if you can't hear it very clearly.
Look, I know that you're not working at the moment, son, but it'll work out. If you can help me, you'll be able to get the carer's pension. And this house, it'll be all yours when I'm gone.
Yeah, okay.
Good on you, son. Yeah.
Yeah.
Yeah. Yeah. Hello.
Hello.
Yeah.
It's very nice, is it?
Oh.
Ian, your father had a good day today. I'll see you next week. See you, Richard.
Thanks, mate.
Richard, I want you to sit down there on the chair and then I'll change the sheet. Please.
Sorry, mate. Didn't realise you were coming in today. Dad, you need to get changed. He's a stubborn old man. Never does anything for himself.
Hey, Ian, your father seems to be a little more tired than usual. Does he eat anything today?
He has his food. I don't stand over him and make him eat.
Hi, Richard. How are you feeling today? There is a few bugs in the corridor. Are you going on holiday? Or are you going somewhere? Richard! Richard! I'm really concerned. What should I do?
Sometimes families find themselves in difficult circumstances, and it's hard to know what's okay and what's not okay. Caring for someone with increasing needs due to dementia can be difficult and stressful, but there are services to assist. If you are working with someone you suspect may be neglected, even if unintentionally, the best line of action always begins with a conversation with your supervisor about what you've seen. Take notes of any concerns you have so you can be accurate. If you suspect someone is unable to take care of themselves and is at high risk or has been left alone, you should call police on 000. Sometimes people who are caring for older family members or friends may not realise there are services available or may be too ashamed to ask for assistance. In such cases, a family meeting is important to see if there are other siblings or family members to assist, and to let the carer know of options including counselling, respite care, and other carer support services to assist. Elder abuse is a difficult topic. Sometimes carers experience poor mental health, can burn out, and don't know how to assist a person with dementia. If we can assist people early, we can reduce the likelihood of neglect. If you need more information or would like to speak to someone about someone you care for, please call the Elder Abuse Hotline, 1800 Elder Help, 1800 353 374, and you will be directed to the relevant service in your state.
I might just stop there with that bit of the film, and really to, I guess, reinforce a few quick points from that film. The first, of course, being that all the people within it were actors, so no older people were harmed in the production of this film. That's the first bit. The second thing is the script for this film was actually devised with researchers at NARI in conjunction with a whole lot of services, older people, and family carers. So we all got together as a group and collectively wrote this script. And that's why you might have noticed in the credits that there was a lot of thanks given to the various agencies that assisted us with that process. The third thing I wanted to, I guess, illustrate or pick up on from that film is neglect is not something that occurs sort of immediately. It can often unfold over time. People may start with the best of intentions, but are worn down. Carer stress is a real issue. As we saw in this particular film, the son Ian started off with the best of intentions, but then, by the end of it was barely able to take care of himself in some respects. And his own mental health was deteriorating as a result. So, it is a gradual process in many instances. And the last point I want to bring up is very often the people who will observe neglect over time are the ones who are the least qualified or least trained to effectively respond to it. So in this particular instance, we have a home care worker who's going in, consistently. They built up a relationship. They're seeing things that are problematic. They're not entirely sure what to do until they've got to this crisis point where they're worried that this older person has basically been abandoned in their home and that the son has basically packed his bags and headed off somewhere else. So it really leads us to the question of what do we do when we come across neglect, and how might we effectively respond to it, and how might we make that response in the context of increasingly diverse populations. So here is where I really want to talk about some alternative models and approaches, and I'm not going to give you a comprehensive shopping list, but just some ideas that you might consider applying in your practice. I want to start by going back to that model I shared with you earlier on. And here's where I really want to focus on those protective factors at the macro system. And so I've popped all those things in bold. What we find in a lot of communities, diverse communities, now to obviously varying degrees, and certain things are more important and less important depending on the community. But often there is a strong sense of community cohesion within particularly diverse groups, particularly marginalized groups. So that sense of kind of community cohesion is important to harness. Just as it takes many a village to raise a child, so too it takes a community to look after older people and each other. Spirituality and resilience is also a really important dimension that needs to be harnessed. Now, we may have varying views about spirituality, religiosity, resilience, etc. But in some communities, that is the real anchor for them, and a very important, measure through which they derive meaning of the work that they do, and a very important way to amplify positive aspects of care, especially in diverse communities. Likewise, the value of motherhood. Some of us might think, oh, well, what is this value of motherhood business? Isn't that a bit sexist, or, putting women and mothering on a pedestal, etc. But actually, if we also consider that older women are really vulnerable to being abused, then we also need to think about the kind of, and that most perpetrators are adult children. What is the value of motherhood in these communities? How do we amplify the kind of positive aspects of mothering and motherhood that is there, and that kind of reciprocal relationship that you often see in many communities, where people will say things like, well, my mom took care of me when I was a kid, now it's my turn to take care of her. That kind of reciprocity, that's a really important thing to harness. Loyalty to family and respect for older people. These are all really crucial protective factors that we can actually play on in our interactions with diverse communities to kind of bring home that point. Now, loyalty to family, value of motherhood, spiritual resilience. These are not precursors for, well, let's pull down the hatches and we're not going to engage with services. Rather, it's about services making that point. These are the strengths inherent within families, and the services are there to support them. So I wanted to just share with you some insights that we found from recent research we did with CALD communities across Australia with regards to dementia care, where we also will see a certain amount of neglect. What we found with services, particularly ethno-specific services, was that they were really critical boundary crossers. Right? So what they did was they mediated between boundaries of culture and dementia. So what is this kind of clinical condition that people might have never encountered before, and the kind of cultural imperatives to look after an older person within the family. They mediated between community and systems. So what is a community, enhancing community understandings of dementia, enhancing community understandings of acceptance, and also understanding, enhancing understandings of health and aged care systems. How does my aged care actually work? How do you navigate this? In doing that, we found these boundary crossers used English and other languages very strategically, and likewise you might consider doing the same in your own practices. Sometimes it's really effective to use English words for certain conditions, and sometimes it's more effective to use other language. So it's not always an either or proposition, and that's partially about also mediating between clinical and cultural terminology, right? So you might use clinical terms when in fact those are safer terms to use than cultural ones, where in fact, the cultural words for it might be really pejorative, and you don't want to put families offside or people offside. Ultimately, it's really about building trust and rapport. And one of the really crucial ways that providers can build that trust and rapport is actually to assist with service navigation to improve access. That is really quite important, helping people actually figure out where they need to go and get there in a timely way. Right? So it's not just these kind of, oh, go talk to so-and-so, they'll figure it out for you. And then what ends up happening is, families are kind of going from point A to B to C to D to E, and it's just this endless loop. And finally, last but not least, it's about service providers not supplanting the family's role. That's really important as well when you're dealing with diverse communities. So you don't pretend to say, well, we're going to come in and we're going to be, we're going to take over. In fact, as one of our providers said, we are at pains to say that we're not going to come in, we're not going to take over. We're here to do, quote unquote, as she said, the dirty jobs, right? So you can enjoy a beautiful time with your family. So we want to make the time that you have with your family something that is special and sacred by helping with other things that might be causes of tension or disruption. So that's some ways you can actually preempt and respond to carer stress. The other thing we wanted to quickly talk about here is dignity of risk. And really, you might have come across this idea quite a bit in your various activities, where the idea of dignity of risk is that we allow people to take a certain amount of risk, right? And that there is a dignity that is afforded to people through the risk taking, and there's therefore subsequent enhancement of personal growth and quality of life. And now there is work to show that when you allow people, or when you give people, rather not allow, when you give people autonomy, it actually improves social interaction, their health, their capacity to live independently, to construct their lives in accordance with their values and personality, enhances self-determination and feelings of worth. Whereas on the other hand, if we were to go in and say, well, this is a terrible situation this older person is in, is completely unacceptable, there's high degrees of self-neglect, it's, we've got to just put them into residential aged care, that's where they really need to be properly looked after. We've got to be so careful, because there's a high risk of, or being overprotective and of actually patronizing and smothering a person, and of really taking away hope. That's critical, and diminishing the person and the capacity to fulfill their potential, irrespective of what stage of life they're at or what capacity they do have. Now, I want to put a few caveats around this, because I don't want to just sort of make it sound like, well, if someone's got advanced dementia, you're not going to just sort of say, well, they can live at home for as long as they like, and set the stove on fire, and their desire is to cook, and therefore we will support that by letting them set the house on fire. Of course not. Of course not. What we do need to always consider when we are affording people and working with them to enable them to take a certain amount of risk is, What is their decision-making capacity, right? So does this person have the capacity to make an informed decision? Do they have all the information they need? Should a family member or a GP be consulted? What is a reasonable risk? That's always a tricky one, right? Because is it something as simple as the choice of food they might want to eat? Or is it something a bit more complicated, such as the refusal of care? Obviously, you need to keep sufficient documentation of this process, and you've also got to operate within your scope of your role and of your organization. So, you don't want to obviously step outside of that and overextend yourself in either of those instances. You need to document what's been discussed, acknowledgement of potential risks, and the consequences of those risks. Now, this all works really well, for example, when you've got a person who has the capacity, who still has capacity, may not have functional ability or high levels of functional ability, but still have capacity. But what do you do when you are dealing with someone who may not have those choices, right? Well, then I'd argue we need to think about dignity and risk more in the context of an ethics of care. And then we've got to really work with families and patients to understand what is the meaning of the concept of dignity as used by these patients and their family. What is the quality of the caring relationships between the patient and professionals, between their family and their social networks? And can they be actively involved in this? And finally, last but not least, what's the social position of the patient? Are they someone who is from a culturally and linguistically diverse background? Have they had a history of mental health issues? Maybe the Aboriginal Torres Strait Islander? What are those sorts of bigger picture drivers, if we think about their model, that are going to shape their experience of care? I won't spend too much time on this slide because I know Claire's going to talk about it a lot more. But really just to, I guess, flag that advanced care planning can be a very effective way to prevent neglect. And it's really crucial, especially as you get towards the end of life, when people are unable to make or communicate decisions for themselves. However, even in the instance where there isn't an ACP, we did some research at NARI, again, involving staff from Western Health and patients from Western Health, and we asked with regards to end of life, what actually matters? So in the absence of an ACP, what is it that really matters to people and that will minimize the risk of neglect? And what we found older people said was clear communication and coordination across health services, being socially engaged, being supported to stay at home, timely pain relief, and being treated with respect and dignity. Similar things were reported by families, but in addition, families said, look, it's really important for us that our relative is kept physically clean and that they not experience any indignities towards the end of their life. Families also appreciate when they get an opportunity to grieve. And this was a really nice quote, I thought, that we could sort of talk about, where this bereaved family member said, actually, look, they didn't try to rush us out at all. The nurse didn't go, like she stayed, even though it was past her shift, she stayed. Because she said she didn't think it was fair to swap shifts, to change at that stage, which we really appreciated. She was the person who'd been there the whole time, and she was there then at the end, which was really lovely. So when you think about what I was talking about earlier, with regards to how you broker those relationships with your patients with regards to carer stress, or when it's regards to that dignity of risk, on the ethics of care, you can see that it's really about building that rapport, that trust. Exemplifying that respect, sometimes, yes, maybe it is about staying a bit later on than you need to, but it does make a huge difference to people and to families. Now, finally, I want to end by really offering a message of hope to you. And this is that kind of theoretical flag I kind of talked about at the beginning of my lecture. There are tensions that come up when we talk about neglect in the context of diversity, and just neglect more broadly. One is we want to respect people's choices, but we don't want to see them hurt, right? So we obviously want to look after them. That's why we're all doing what we're doing. One tension that we have is sometimes in wanting to look after people, there's a risk of being overprotective, that protectionism. On the other hand, there's also this kind of tension of, oh, look, it's not our job to play God, to encourage them to think about advanced care planning or to encourage them to think about all the services or bits and pieces of assistance they might need along the journey. Or, we've got to kind of step back and let people do what they need to do and wind their way through their journey as it unfolds. I actually think these are false dichotomies, and there are better ways we can think about these tensions. And this is where I'm going to draw upon anthropology a little bit. So I'm drawing from the moral anthropology of care here, and the references at the bottom. So the first thing I want to do in that is a point that Cheryl Mattingly makes, which she says, look, to do is to suffer. And what that basically means is that every action has a consequence, right? So you as a health provider, as a service provider, whatever you do or don't do will have a consequence. Every action has a consequence, right? So you have to suffer the consequences of your actions, no matter what they are, successful or unsuccessful, but that will happen. So to do is to suffer. But everyday life, those decisions you make, they are micro decisions in many respects, right? They're micro engagements that you have with patients, with families, with each other. And every micro engagement that you have is an opportunity for hope, for experimentation, and for reflection. Right? So real life, everyday life is very dense. And so it's not a one-off singular event that, right, that leaves no opportunity for recalibration. So that's the second point I really want to make to you, that you have always in your role an opportunity for hope, experimentation, and reflection. And then the third thing I want to tell you is that every event and interaction that you might have with your patients is part of a larger life story, right? It has an antecedent and it has an afterlife. It is not the be all and end all in itself. Things happen in the lead up, things happen afterwards. And in those lead ups and afterward events, those antecedents and afterlives, there is again that space to tinker, to change, to experiment and reflect. So we have agency, we can respect choices, we won't always get it right. Neglect is a very difficult issue to grapple with, but I guess just to take hope that there is space for change and alternatives all the time. And I'll stop there. Thank you very much.
Thanks for that, Bianca. That was fantastic. Sorry, I was caught up in writing down some notes based on what you said. We've had quite a number of comments come through, which are more observations and kind of a here to what you've been to the discourse that you've provided. So Nicole from ACAS wrote, "Oh, Bianca, dignity of risk, you are a kindred spirit," and this is where ACAS reside with their work. We live with the need to balance considerations around a person's capacity and their dignity of risk. There were similar comments to that effect as well, and also commentary around leading questions around why I guess the journalists would single out CALD families' request as different from the advice for all families as well. There was also a comment by Khan, who reports about a family member and a grandparent who felt that the system around getting a diagnosis and support with their grandparent was particularly challenging with GP as well. So I think your commentary has really struck a chord. So thanks very much for that. Our next presenter today, to pick up on the thread from Bianca, is Claire Thurstans. Claire is a lawyer and project lead at the Seniors Law Team at Justice Connect. She works mainly in elder abuse and elder abuse prevention. Justice Connect has a health partnership with CoHealth, and Claire works on site at CoHealth, COVID permitting. And she works directly with her clients. Claire is leading an elder abuse prevention project at Justice Connect entitled Safeguarding Now, Preventing Future Abuse project. Claire's experienced in both health and ageing sectors and in recent years worked on the Aged Care Royal Commission. So just like to welcome Claire.
Thank you so much, Carla. Thanks to everybody for spending time with us today. And thank you to Bianca for such a fantastic presentation. I always love hearing you speak. I always feel invigorated and excited afterwards. So I'm sure the audience is feeling the same, which is great. So I'm just going to share my screen, if you bear with me just for a minute. Can everyone see that all right?
That looks good, Claire.
Fantastic. Okay, well, I'd like to start with an acknowledgement of countries. So I acknowledge the traditional custodians of the lands on which I'm coming from today. For me, that's the Wurundjeri people of the Kulin Nation. And I acknowledge all elders past, present and emerging. I acknowledge that sovereignty was never ceded, and this always was and always will be Aboriginal land. So in terms of what I'm going to cover today, I'm going to go a bit more into the preventative side of things, so future planning specifically, and how that can be used as a tool to help prevent neglect. I'll then talk a bit about some research that I've been doing this year into what stops people from planning, future planning for their older age. And I'll then speak to what stops workers in health environments and in social services from helping their clients with future planning. And if we have time at the end, I'll touch on guardianship and administration. So neglect in diverse communities, that's what we're talking about today. I think Bianca's really given a very comprehensive overview of what neglect is, but I did want to reflect a little bit on the neglect that we see in our day-to-day work in the seniors law team at Justice Connect. As Carla mentioned, I'm based at CoHealth when we're not in lockdown, and we get our clients referred to us from CoHealth, so they're CoHealth clients. And we commonly see people who are experiencing neglect, whether that be self-neglect or care neglect. So self-neglect, the type of self-neglect we see may be due to someone experiencing mental illness. It may be due to them having an acquired brain injury, some sort of physical health condition that is preventing them from being able to care for themselves in the way they need to. So whether that's manifesting in a living situation that's really untenable, so a housing that's not appropriate, just a sort of an unlivable environment, or it might be manifesting in them not being able to access the medications that they need or care and support at home. And we also see people who are experiencing neglect at the hands of their carers. So as Bianca mentioned, often carers are family members and loved ones, and we often see situations where adult children are living with older people but failing to fulfil their caring obligations. And sometimes that can be more on the deliberate scale, but much more often, I think, is the unintentional type of neglect that Bianca sort of alluded to throughout her presentation. And as Bianca mentioned, neglect and the causes of neglect are very, very complex, and I'm not going to go into them in any detail today, but there are risk factors on the side of the older person, so things that might put an older person at risk of neglect in particular include being really, really dependent on their carer, also having a mental illness, not understanding their rights or entitlements, and not being able to navigate the services that they need can also put them at higher risk. On the other hand, a carer might be at higher risk if they have other caring responsibilities for children, for example, if they're managing complex situations in their own lives, whether it be substance abuse issues, financial difficulties, whatever it might be. And the diverse communities that I'll be speaking to mainly today are culturally and linguistically diverse communities, and also the Lgbt Iqa+ community. So we often talk about responding to neglect, and I know all of us will have clients who present to us with symptoms of neglect that we can pick up on. But like I said, what I want to focus on today is what we can do to prevent neglect and what we can do to prevent neglect becoming more and more serious over time. And one of the tools we have available to us and that older people have available to them is future planning. And I'll talk a bit more about what I mean by future planning in just a minute. But before I do, I want to start with a story about a client. This client is not a real client, but she's more a mishmash of lots of clients who we all see every day. And I'm sure that Hua's story will resonate with many of you. So Hua is 72 and she's originally from Vietnam. She came to Australia after marrying her husband, who was Australian Vietnamese. Hua spent much of the last 30 years caring for her husband and her 3 stepchildren who are from her husband's first marriage. Her husband died a few years ago. She speaks limited English, she's pretty socially isolated, and she has limited literacy in English. A couple of years ago, Hua invited her stepson to move in with her following his divorce. And she believed that he would care for her as she got older. But she's found that he's really struggling following his divorce, and he often takes her credit card to go drinking and gambling. Hua's health is declining, and she doesn't often leave the house anymore. She's finding it harder to get to the bank, to get the medication that she needs, and to cook and clean. So Hua is already experiencing neglect and financial abuse, but you can sort of see that she's at risk of this neglect becoming more and more significant as she gets older and her health continues to decline. So I'll come back to Hua as I'm talking today, but I just wanted to start with a story because, you know, we're all here because we care about our clients. So I think instead of having a bit of an abstract conversation, it's nice to bring it back to the people we work with. I'll give a little bit of context about the project I'm working on at Justice Connect, which is the Safeguarding Now Preventing Future Abuse project. So the mission of the project is to help prevent elder abuse, including neglect, by empowering more people to plan for their older age. And the groups that we're targeting in the project are the Lgbt Iqa+ community, the CALLED communities in Melbourne, including and in particular the Chinese and Vietnamese communities, and also people who are ageing alone, who are socially isolated, who don't have a lot of support from other people in their lives. And the reason we're focusing on these groups is because we know they face additional barriers when it comes to planning for the future when compared with the general Australian population. And there are 3 phases to the project. I won't bore you with them too much, but just to give you a bit of an idea of where we're up to. So the first phase of the project was really, we wanted to understand why people don't future plan, so why people aren't planning for their older age. We know that only about 10 to 20% of Australians future plan, and that diverse communities face additional barriers. So we really need to understand what these barriers are to help us overcome them. The second part of the project is designing ways that we can make future planning easier for people, and so we can help empower people to future plan. And we're up to that stage at the moment, so we're in the process of designing a conversation guide that will help people plan for the future, and it will be targeted particularly, there'll be one for the Vietnamese community in Melbourne and one for the Lgbt Iqa+ community. And the final stage of the project will be to implement this conversation guide and to start rolling it out through education sessions. But that's just a little bit of context about the project, so you can see where all of this sits. But now we'll get a bit more into what is future planning. So many of you will be familiar with this. Future planning is planning for older age in relation to 3 main categories. So it's planning in relation to finances, that includes property, planning in relation to healthcare, and planning in relation to day-to-day lifestyle. And it includes planning who would make decisions for somebody if they lost their decision-making capacity. So, for example, if someone's getting older and they're declining cognitively, who would be able to step in for them, or who would they want to step in for them and make decisions on their behalf if they weren't able to anymore? And it also includes planning just generally what someone wants their older age to look like and what they would want to happen if they faced obstacles or challenges or changes in their older age. And it's not an easy thing. Future planning is complex, and it's a big thing to grapple with. We see it as this 4-step process. The first step is thinking about what we want our older age to look like. Obviously, that's an extremely important first step. The second step is talking to people that we trust about what we want and also asking for their help. Thirdly, it's important to write down any decisions made and share those with family and loved ones. And finally, you can formalise these arrangements and decisions in legal documents when that's appropriate. And because, I am a lawyer, we are focusing in part on the legal documentation of planning for the future, but also we're focusing more broadly on just the conversation. So here are some of the questions that we might be thinking about when engaging in future planning. Who do I trust to support me or to make decisions for me if I can't make those decisions anymore? Who would I trust to pay my bills for me, to have access to my bank accounts, to decide which doctor I'm going to go and see, to decide where I'm going to live, which friends I'm going to see? All of these things, all these decisions that need to be made if someone loses their ability to make their own decisions. Who would they trust to make those decisions for them? Do they have someone they trust to make those decisions for them? Where do I want to live? Most of us want to stay at home as we get older, but not all homes are appropriate for older people. So what are the things we could be doing now to put safeguards in place so the home is an appropriate space later down the track? What support might I need at home as I get older? And you can see in the case study I've just shared, you can see in her situation, she does need a bit more support at home now. So what are the things she could be planning to get in at this stage? What sort of lifestyle do I want in my older age? And that might include things like Bianca mentioned before, the importance of spirituality and religion. To some people, it might include the importance of being social, seeing friends, seeing family. How can we plan for that and build that in? And also, really importantly, what medical treatments do I want at the end of my life? What is important to me when it comes to healthcare? Is quality of life important to me? Is longevity of life important to me? Just grappling with all of these questions. So all the things I've just discussed are, both legal and non-legal health, social services, lots of different things. But in terms of the legal options specifically, some options for future planning include, doing a power of attorney document in relation to finances and in relation to personal matters. So that means giving someone the power to make decisions on your behalf. Also doing advanced care planning, doing an advanced care directive with your health professional, or seeking legal advice about, if you were in hospital or in an ambulance and the doctor needed to speak with somebody, who would they call first? Do you want them to be calling that person? So, for example, in Va's situation with her stepson living with her, perpetrating financial abuse against her, she may not want the doctor to call her stepson as the first person to make a medical decision for her. So seeking advice about that from health professionals and lawyers can be really important, an important part of future planning. That's just a couple of examples of the legal options available for future planning. So that's just a brief overview of future planning in a nutshell. But how can this prevent neglect? Well, it's one tool. It's not going to stop neglect altogether, but it can prevent it. And by planning ahead and putting things in place for the future, older people are in a better position to maintain their independence and autonomy and control in their older age. Those things are so, so important to all of us. And this can help reduce the risk of neglect. It can reduce that dependence on carers, which can lead to a higher risk of neglect. And it can reduce the risk of self-neglect as well. I see future planning as a sort of self-care for our future selves. So I'll talk now a bit about some research that we've done this year about what stops people from future planning. And we really focused our research on diverse communities. And we found that, interestingly, individuals and communities don't have the same barriers. When you ask each person, why haven't you done any future planning, or what's preventing you from doing future planning, you'll get very, very different answers, depending on who you're speaking with. So I'll go through a few of the themes we've picked up in our research now with you. So the first big barrier that is preventing people from planning for their older age is simply that people are reluctant to think and to talk about getting old, getting sick or dying. So let's drill down into that a little bit more. One of the reasons for the reluctance to have these conversations is fear and avoidance. We are scared of the topic of getting older, a lot of us, and getting sick. We don't like to think about the fact that we may lose our independence, that our bodies may not behave in the way that we want them to, that our minds may deteriorate. They're really scary things to grapple with, and we tend to avoid it and put off the conversation or even the thoughts about it. We've heard that from a lot of the community members we've consulted with this year. Another reason for this reluctance to have conversations about getting older or getting sick or dying can be due to spiritual or religious beliefs. So if someone believes that a higher power is determining what will happen to them, they may feel reluctant to talk about it because there's no point, it's already mapped out. So this belief that the future is God's will or a matter of fate can actually prevent people from engaging in this planning process. Also, people may just have a carefree attitude and, power to them, that's great. People want to live in the moment and not worry about the future. I'm all for that, generally speaking, but when it comes to future planning, I think there's just no denying the benefits of it. But let's turn now to specifically cold communities. And I do hate to talk about cold communities as if they're one homogenous group, because we all know that's not the case. But, I'll use that term for ease of reference. And Bianca mentioned this in her presentation, I think. Some cold communities have these really strongly ingrained expectations that older people will be looked after by younger generations. And this expectation can actually lead to a reluctance about having these conversations about getting older or planning for the future. So, for example, in Chinese culture, this concept of filial piety, which is the attitude of obedience, devotion and care towards parents and elder family members, is really, really ingrained. But this is a really common cultural expectation all across the world. So we see it in European cultures, for example, in Italian and Greek communities. We see it in African cultures. So, for example, in South Sudan, there's a really strong expectation by older family members that they will be cared for by the younger generations. We see it in India. We see it all across the world. So when an older person holds this assumption, they may feel that someone else will manage the future for them, so there's no need to plan. And then there's also often an accompanying assumption that, the family's got this, they know what to do, they know what I want. And so it may be just a sense that there's no need to have a conversation about it. When we look to the Lgbt Iqa+ community or the rainbow community, there's different reasons again for this reluctance to think or talk about getting older. So some people in the Lgbt Iqa+ community lost loved ones in the AIDS epidemic. And we've met with community members this year who told us that they believe that because they lost their loved ones in the AIDS epidemic, they don't feel that they should be here. And that sense of guilt can lead to a reluctance to discuss getting older. People in the rainbow community also have faced a lot of discrimination from various service providers over the year based on their sexual orientation or their gender identity. And this can lead to a real reluctance to have conversations about getting older, particularly with health and service providers, because of this fear of discrimination. And also, interestingly, some of the research shows that there is this perceived emphasis placed on youth and beauty in the gay community, which makes it harder to discuss issues relating to ageing. If we go back to Hua, Hua is reluctant to talk about getting old and sick, so she's facing this barrier herself. She's always been the caretaker. She's always looked after others. She looked after her husband. She looked after her 3 stepchildren. She isn't comfortable talking about herself. She's fearful and anxious about the future, and she's trying to avoid these feelings from coming up. Hua expected that her stepson would step in and look after her, but he's obviously not doing that. But even though he's not, he's neglecting her, she still wants to believe that he will come around. Now, moving on to the next barrier that we've identified through some of our research.
Claire, I might just let you know we've got about 5 minutes to go.
No problem. People don't have anyone to help them. This can be a huge barrier for people planning for the future. So particularly for people who are single and live alone, for people in the rainbow community, particularly if they're single and estranged from their biological families, and some people from culturally diverse communities, particularly if future planning isn't common in their community and there aren't culturally appropriate services, they may feel that they just have no one to help them with this process. So again, if we go back to Hua is anxious about the future because she can see that her health is going downhill and that things are becoming more difficult, but she doesn't feel as though she has anyone to help. She's socially isolated. She's facing language barriers. She has 2 other stepchildren, but she's not really seeing them very often. And she doesn't feel like she can talk to anybody about this. And the final barrier I just wanted to touch on was the fact that often there's just a lack of understanding or awareness of what future planning is or how to do it. And we know in particular that people from culturally diverse communities are less likely to future plan. And in the same way, Lgbt Iqa+ people may not be aware that future planning applies equally, regardless of, for example, whether or not they have a same-sex partner. So let's go back to Hua again, who hasn't dealt with many social or health services before. She's never seen a lawyer. She's been here for a very long time, but her husband usually dealt with those matters for her. She doesn't know where to start to put things in place for the future, and she feels nervous and ill-equipped. So they're just a couple of the barriers that people are facing when it comes to planning for their old age. But I wanted to switch now and talk about what's stopping us as workers from helping our clients with future planning. And we've spoken with health workers this year about this question. We've asked, I should say from the outset, actually, I know that a lot of health workers and social services workers are having these conversations with clients, but we know from the research that not everybody is and that a lot of people aren't. And these are the reasons that health workers told us that they're not helping their clients plan for the future. It's not my job. There's not enough time. I don't know how to bring it up. it's an awkward conversation to start. I don't know who to refer them to. And there are cultural and language barriers. And these are all really legitimate barriers to workers bringing these conversation topics up with their clients. But the reality is we are uniquely placed as workers to make a huge impact on people who are at risk of neglect or who are experiencing neglect by helping them with this future planning process. And I just wanted to share a couple of suggestions and things that we can do to sort of help with this process. I mean, first of all, I think being inclusive is so, so critical. Visibility really matters. You know, for the rainbow community, that can be as simple as wearing a rainbow pin, wearing a rainbow lanyard, having posters up saying that we are, you know, a rainbow community friendly environment. These things may seem tokenistic, but I know for people in the community, that means a lot, because suddenly that fear of being discriminated against can be overcome. They know that they can have conversations with the workers about their future and getting older, about the neglect that they're facing. For culturally diverse communities, you know, being inclusive might look like being culturally sensitive, understanding what's culturally appropriate, the ways to communicate, what's the right way to communicate, not feeling scared to start a conversation because of a language barrier. It's a really big one, just making the effort to build that rapport. Secondly, starting the conversation, talking to older patients and asking if they've done any planning for the future, and offering support, offering to provide resources and referrals to patients to help them with future planning. For example, the conversation guide we're developing in this project at the moment, and I'm happy to share that with you once it is finalised. But I just wanted to round things out quickly, just to bring back to Hua and just to see this in action. So Hua sees a health worker, Annie, on one of the rare occasions she's leaving the house. They could get by speaking English, but Annie calls an interpreter. And Annie really spends the time building trust with Hua. She asks her how things are going at home. She notices from Hua's demeanour that she seems a bit distressed, that she's looking a bit dishevelled. She gets the sense that Hua is struggling. And what Annie does is she helps Hua with her medical treatment, of course, but she also offers to put her in touch with a social worker and a lawyer. And over time, and it doesn't happen straight away, the lawyer helps Hua do a power of attorney. So she appoints one of her stepchildren to help her with paying her bills, managing her finances. And she also starts a conversation about advanced care planning and puts her in touch with her doctor. And she also gives Hua advice, the lawyer gives Hua advice about options of getting her stepson out of the house. Meanwhile, the support worker gets Hua some home support and links her in with the seniors group. So you can see from just these little actions, and I think Bianca mentioned them as micro actions that we do in our day-to-day work, this can make such a huge impact on older people's lives, older people who are experiencing neglect or at risk of neglect. You can see that Hua is now at a much lower risk of neglect because she has these supports in place. She's done some planning for the future and she feels less isolated, fearful, and more positive. And I might finish up there. Thank you.
Thanks so much, Claire. I just think that the work that you're doing and, you know, the work that Bianca's doing is just ever so important, particularly at the moment. I know from my perspective as an elder abuse liaison officer that when people do have an advanced care plan, it really assists family, the older person, the formal supports that are in to help to navigate those things in a way that's meaningful for the older person. So we are running pretty low on time, and we haven't had as many questions as we had anticipated. But I think I know for myself, every time I thought of a question, both of you immediately answered it on your next slide. So thank you ever so much for your presentations today. I would just like to pose a question to both of you, I guess, to round it out. How can we work better across sectors to reduce the risk of neglect and to support older people experiencing neglect? We might stick with you, Claire.
Yeah, absolutely. Well, I mean, I think the health justice partnership model that I'm working in with Justice Connect and Co-Health, and we have other partners in Victoria and New South Wales, it's a very effective model. I think, you know, collaborating and getting people from different sectors with different expertise is so, so critical, and approaching neglect from multiple angles. So there might be a health angle, there may be the social work angle, there may be the legal angle, there may be other angles as well. So the more services we can bring in together, the more successful we'll be. One of the things that we do in our health justice partnership, for example, is we often attend case conferences that are held by health and social workers. And during those meetings, we can actually offer insights from a legal perspective, and then people can refer to us, we can refer to them, we can bring in housing teams, whatever we need. So I think just having those open channels of communication and that systems-based approach is really critical to addressing neglect in a holistic way.
Thanks, Claire. Bianca?
Yeah, I'll just add to that. Wholeheartedly agree with Claire. The evidence tells us that a multidisciplinary response is absolutely integral to an effective resolution of elder abuse. So whichever form it takes. So I absolutely agree with that. And I think there's also, in addition to that, an advocacy piece that we all need to do in terms of understanding the broader determinants or drivers of elder abuse. You know, things like ageism, like poverty, like structural discrimination, etc. And obviously, you know, that sort of stuff is not going to be solved in a day or a week or a month. It's a generational thing. But paying attention both to those upstream drivers is also really important.
Thanks, Bianca. There's a question that's come through from one of the attendees. Where do you recommend clients keep an advanced care directive? Who should have copies, and do these need to be certified? That might sit best with you, Claire.
Yeah, absolutely. So we always suggest that the advanced care directive is provided to the person's GP if they have one, or their health provider, also shared with family members or loved ones, and in particular not only shared the paper version but a discussion, a conversation had about what's in it is really, really critical, and the person keeping one for themselves as well. And yes, it is always good to get certified copies, but I think that's more of a provider-based requirement more than anything else. A doctor has to have regard to any advanced care directive, regardless of what form it's in. It doesn't have to be in a particular written form. There are more formal forms available, which are good to use, but it can even just be on a notepad, and a health provider still needs to take that into account.
Thanks, Claire. I think we've reached the buzzer for 2:30. Thank you to our expert presenters and to Grace from the Elder Abuse Prevention Network as well. We really appreciate your time and expertise and sharing that with us. Just a reminder to everybody that this Friday is Australia's first Ageism Awareness Day, which coincides with the International Day of the Older Person and Seniors Festival in October. So we'll be putting some links in the resources for that. But we might close the event. Thank you, everybody.